Awesome. Well, thank you everyone for tuning in today. My name is Dr. Amir Otarodi. So, I've been here at Eisenhower for 1 year now. Just a little bit about myself. I grew up in Southern California, Orange County area. I did my undergraduate at UC Irvine for my basic sciences degree, and then I went to medical school there. In addition, I did a residency in orthopedic surgery at USC in Los Angeles, and then I ended up going to Washington University in St. Louis for a shoulder and elbow fellowship. So I was in practice in San Diego for about 8.5 years before making the change and coming to Eisenhower for a good, job opportunity. And now I've been here for a year. So happy to be here, and I'm happy everyone's here to talk with me about rotator cuff tears. So, we'll start with a little bit of a background on rotator cuff tears. And the objectives of today's talk are to, one, just describe what the rotator cuff is, what its function is, understand the signs of a rotator cuff disorder, and then talk about diagnosis and, understand the indications for repairs. So this is a very complicated topic with a lot of things we could talk about. That would be, too much for the scope of this discussion alone, but there's a lot of different treatments ranging from repairing the rotator cuff to transferring muscles and tendons to even doing shoulder replacements. But for the purposes of this talk, we're going to be focusing on when to get your rotator cuff treated non-operatively and when to get it repaired. So let's start with the anatomy. So the rotator cuff. The rotator cuff is the most important group of muscles and structures in your shoulder. So the shoulder is essentially a ball and socket joint. The ball is the top of the bone in your arm, and the socket is the edge of your shoulder blade. Well, the rotator cuff are these four muscles that come off the scapula, as you can see on this picture on the upper right hand. And the muscles cross a joint and they turn into tendons, and the tendons wrap around the top of the bone in the arm called the humeral head or the ball. Well, all muscles are anchored to bones by tendons. So when the muscles contract, the tendons pull like ropes and get our skeletal joints and, our skeleton to move much like a puppet or, a puppeteer would put strings pulling on the different bones. So there's four muscles. And the rotator cuff, when we talk about it, we talk about it as a whole, but there are four separate muscles and four tendons. One is called the subscapularis. It's a tendon in front. There's the supraspinatus, which is a tendon over the top, and the infraspinatus and teres minor, which are the muscles in the back, muscles and tendons. So what is a function? So the scientific term for it is concavity compression. So essentially what it does is it sucks the ball into the socket. And this is very important because when you suck the ball into the socket, now other muscles pulling on the upper arm will lead to a rotational motion in your shoulder. So if you look at this diagram on my right, you can see there's one rotator cuff muscle being shown here. That's the supraspinatus with the arrow pointing horizontally. Well, that sucks the ball into the socket. And then the deltoid muscle, that is the muscle on the outside with the arrow pointing up. Now, when that pulls upwards, because the ball is centered in the socket, it gets your shoulder to pivot or rotate, and now leads to an upward elevation of the arm in general. So essentially, the rotator cuff keeps the ball sucked into the socket. So when other muscles pull on the arm bone, it gets your shoulder to rotate. And this is how we kind of elevate our arm overhead, position it out to the side, and position our hand into space to do all of our day-to-day activities. So rotator cuff disorders, they're the most common cause of shoulder pain, especially in patients as we get older and also overhead athletes. They're very common, and the incidence increases as these activities go on. So every year, over 600,000 surgeries are performed in the US alone just for rotator cuff disorders. So we should first talk about the types of rotator cuff tears. So you might hear the terms partial thickness tears, complete tears, full thickness tears. So what's the difference? So a partial tear means that only a portion of the tendon is pulled off the bone. So if you look at this diagram on the right, you can see the ball, you can see the socket, and that structure crossing the joint is a rotator cuff. Well, with a partial tear, the majority or a portion of the tendon is still touching the bone, but some of it is pulled off. So, partial tears can be broken down into low grade, moderate grade, and high grade. And essentially, a low grade is any time that less than 25% of the tendon is pulled off the bone. Moderate includes 25 to 50%, and high grade is 50% or higher. When we talk about full thickness tears, that means that the tendon is completely pulled off the bone. And we also characterize those by size. So they can be small, medium, large, or massive tears. And in general, we break that down, from a 1 centimeter length of the tear for small, medium tears are 1 to 3 centimeters, large tears are 3 to 5 centimeters, and anything more than 5 centimeters or two of the four rotator cuffs being torn are considered massive tears. And this is very important because it helps guide our decision making. So who gets rotator cuff tears? So rotator cuff tears occur because of normal age-related degenerative changes in most cases. There are things that contribute to this, such as overuse, repetitive overhead activities. Whether you were a laborer or had a very strenuous job, these can all contribute. But mostly they occur because of age-related changes outside of a trauma where someone falls on their hand. Um, when you do have an acute rotator cuff injury, most of the time it happens in younger patients, but again, this can also happen in anyone of any age. Brett, we're not advancing.
Move the. Yes.
Oh, there we go. Okay. Thanks. Okay. So back to our talk. So degenerative tears. So as we get older, there's a age-related increase in the incidence of rotator cuff tears. So when you're less than 40 years old, rotator cuff tears are very unusual. When we talk about partial tears, about 4% of patients have a partial rotator cuff tear when they're less than 40 years old. But as you get older, that incidence goes up. So here you can see that with a partial or incomplete tear, 20%, 26% of patients over 60 have a partial rotator cuff tear. So every 10 years or every decade that goes on, the incidence of rotator cuff tears increases. And when we talk about full thickness tears or complete tears, when you're above age 60, 28% of people are walking around with full thickness tears, even if they aren't experiencing pain. It's a very common phenomenon. But as we get above 70, that number goes up. So 65% of people above age 70 will have a full thickness rotator cuff tear. But again, most of these are asymptomatic. So there's been multiple studies on this, and even a very good one showed that if you come in to get evaluated, let's say for pain on one of your shoulders and you're above 66 years old, well, there's a 50% incidence of having a full thickness or equal rotator cuff tear on the other shoulder, which goes to show that a lot of people are walking around with rotator cuff tears, and whether it's one injury or overuse or something like that leads to the development of pain. So it's a very common phenomenon for us as we get older. So why do these tears occur? So there's multiple schools of thought. In the past, we used to think that rotator cuff tears always occur because of impingement or bone spurs. You're lifting your arm overhead and it makes contact with the bony prominence in the shoulder, and that rips through the tendon, causing tearing. But as time has gone on, there's been a lot of research coming out that shows that the tears actually most of the time occur within the tendon themselves as we get older. So the blood supply goes down, the collagen gets weaker, repetitive overhead activity or labor leads to little traumas that progress and develop the partial and full thickness tears. And there's also a genetic predisposition to having tears develop. So some patients will get them at a younger age just because of their genetic predisposition, and some patients could be in their 80s with a completely normal rotator cuff. But in all actuality, the causes are multifactorial, both these intrinsic factors and the relationship with the rotator cuff and the bones and bone spurs around your shoulder do work together to contribute to this. So some risk factors. So we've already touched on age. We've touched on repetitive overhead activity. There's also patient-related factors like smoking. So smoking has been shown to be a significant contributor to the development of rotator cuff tears, and even cholesterol. So when you have elevated cholesterol, that's been also shown to contribute to the development of rotator cuff tears as we get older. And again, family history that goes in line with your genetic predisposition to developing these tears. So what are the causes of shoulder pain? So every time you have a shoulder that hurts, it doesn't necessarily mean you have a rotator cuff tear, even though it is the most common. There's different things that could, overlap and have similar symptoms, such as arthritis. You've heard the terms frozen shoulder, a labral tear, a fracture, calcific tendonitis, biceps tendonitis. These things all overlap, and sometimes the findings are non-specific. So sometimes it can be difficult to differentiate one from another. So what are the common symptoms of a rotator cuff tear? So most of the time, patients complain of pain over their deltoid or their upper arm. It radiates to the upper arm, but usually it doesn't go down past their elbow. And sometimes this is a little bit tricky for patients because they come in saying that my shoulder doesn't hurt, but my arm hurts here. And it's hard to understand how that could be related to a structural issue in the shoulder, but it's called referred pain. So there's something structurally wrong in the upper part of your shoulder. And because of how we're wired with our nerves, it presents as pain over the upper arm. Night pain is a very consistent finding in people who have rotator cuff tears. A weakness and inability to lift the arm overhead or have as much strength as you had before is a sign of a rotator cuff tear. If you had a pre-existing rotator cuff tear and you were doing relatively well, and now all of a sudden your pain's gone worse and you have more weakness, these are signs that the tear has actually gotten bigger in size. And anytime you have difficulty performing your normal overhead activities, that should always raise some red flags for a rotator cuff issue. So when you come into clinic to be evaluated, there's many things we look at. So the first thing we look at is, are you tender to palpation over the front of your shoulder? Can you get your arm all the way overhead when we lift it for you, but then you can't do it on your own? This means that you have decreased active range of motion, but your normal range of motion is intact. That's very common with rotator cuff tears. If you come in and your shoulder is stuck at a certain degree of motion, regardless of whether or not you're moving it or I'm moving it, those point more to other causes such as arthritis or even symptoms or problems like frozen shoulders, and not necessarily the rotator cuff by itself. Another very common finding is having an ability to raise your arm overhead, but then not being able to lower it without substantial pain. This is pretty classic for rotator cuff issues. So here are just some of the things we look for when we talk about elevation. We talk about the ability to lift your arm overhead. Normal should be upwards of 160 degrees. We look at how far you could reach your arm out to the side. And we look at how much you could lift your arm behind your back. So limitations in these motions always point toward rotator cuff pathology, in addition to some other issues. So we test for strength. So we have you put your arm in this thumbs down or empty can position, and we test for strength. That lets us know what the supraspinatus is doing. So if you have a lot of weakness in this position, it makes us think that you may have some pathology involving the supraspinatus. We have you put your arm at the side, and we test for strength against resistance. That also lets us look at the tear in the rotator cuff in the back, called the infraspinatus. We have you put your arm up to the side. That lets us look at the teres minor. This is the rotator cuff that is very unusual for this one to be torn. So it's very rare to have a teres minor tear unless you've had a very massive accident, such as a motorcycle accident or a fall from a ladder or something very extreme. And then this is a very common one. Put your hands on your belly and see if you could bring your elbows out to the side with your wrist straight. If you can't do this, this could be a sign of a rotator cuff in front, a rotator cuff tear in the front, in the tendon known as the subscapularis. So what do we do in terms of imaging? We always get an x-ray, and the purpose for the x-ray is, it doesn't show soft tissues, and a lot of patients, bring this up. However, if you get an x-ray, we could see bony abnormalities. We can see if you have severe arthritis. We can see if there's calcium deposits inside the shoulder. We can see if there's fractures. This would help, us differentiate a rotator cuff tear between versus another problem such as calcific tendonitis or arthritis. However, if you get an x-ray and you see there's significant malalignment, such as on the picture on the bottom right, you know that there's a rotator cuff tear because the ball is not being sucked into the socket anymore. And when we get this x-ray, we know that you have a massive chronic rotator cuff tear that is beyond fixing, and an MRI really is no longer indicated. We can get ultrasounds, and ultrasounds are a great way to look at the rotator cuff dynamically. So these are just pictures of what an ultrasound will look like and what the normal anatomy looks like and how to differentiate a tear versus a normal rotator cuff on ultrasound. But MRI really is the gold standard for imaging all the soft tissues in your shoulder. So on the image up on the upper right, you can see the ball or the humeral head. You can see the socket, and the structure over the top is a supraspinatus as it crosses a joint, turns into a tendon, and attaches to the top of the bone in the arm. If you look at the picture below it, you can see the difference between an intact rotator cuff and a rotator cuff with a very big tear where the tendon is very thinned out. It's retracted to the top of the humeral head, and there's a big gap between where it should be and where it's actually resting now. So if MRI is contraindicated, a lot of patients have pacemakers or metal in their body, and an MRI is just not an option for them. Sometimes we order a CT arthrogram. And with this, we inject dye into the shoulder, get a CT scan, and the dye outlines the structures in the shoulder so you can see if there is a tear in the rotator cuff, such as on the picture on the bottom left. So treatment considerations. So there's not really one way to treat a rotator cuff. We have to take a lot of things into consideration. We take the age of the patient, the activity level, whether this was a degenerative tear or if it was a tear that happened after a major trauma. Is it new? Is it old? Is it a partial tear? Is it a complete tear? And then with a partial tear, what side of the tendon is torn? Is it the bottom or the undersurface or the top surface? And ultimately, the reason for this is there are a lot of tears that we know based off a lot of research and literature are stable and will most likely not get much bigger with time. But then there's other tears based off some of these characteristics that are prone to get rapidly bigger. And if they get bigger, they could end up scarring down and getting to a point that they can't be fixed. So you have to weigh these risks with the patient's health, activity level, expectations, and really tailor the treatment for every patient. And it actually gets very complicated. So a thorough discussion is always warranted whenever you're talking to someone about a rotator cuff tear. So non-operative management. This is a first line for most tears. Physical therapy strengthens the intact rotator cuff and a lot of the other muscles that attach in the shoulder. So there's 17 to 18 different muscles that attach to your shoulder blade. And a lot of times, if you get these muscles strong enough, they could put your shoulder blade back into a normal position where it'll offload the pain related to having a rotator cuff tear. But oftentimes, this requires 3 to 6 months of therapy. It's not a quick process. And in addition, we advise patients to modify your activities. We provide some oral anti-inflammatories and other medications for pain control. And there's also the opportunity to provide cortisone injections. So non-operative management is effective in most patients and has a very high success rate in a lot of tears, especially in partial tears. One thing to note, though, if you have substantial pain at nighttime, there's evidence that that actually gives you a poor prognosis for the success of non-operative management. So this brings us to talk about, let's see, cortisone injections. Or well, let's start with non-operative management. So most partial thickness tears can be treated without surgery right off the bat. So, and small full thickness tears in patients who are a little bit older and have low functional demands can also be treated without surgery successfully. And the reason for this is we could get your pain under control, improve your function and strength, and not have to go straight to surgery because rotator cuff surgery is a difficult recovery. And as we do get older, sometimes age plays into how well we can heal. So non-operative management, cortisone. So cortisone is effective, but we have to use this sparingly because over time, cortisone can be dangerous for your shoulder. Initially, 1 to 2 injections are perfectly safe. It can decrease inflammation. It can make you feel better within 7 to 10 days. And it provides local relief without essentially causing systemic effects. But there are some dangers. So multiple injections. Over time, if you're getting injections every 3 to 4 months for years, it's going to lead to deterioration of your rotator cuff and the other structures in the shoulder. It decreases the production of collagen, which is the main component of most of our tendons. It changes their alignment and makes them weaker. It actually also damages the cells that maintain and repair our tendons and leave us more prone to injury. It actually also increases enzymes that break down collagen. So all these things together over time lead to weakening and thinning of the rotator cuff. So if we ever do surgery on someone who's had multiple injections, we see the remnants of cortisone throughout the shoulder. There's small little crystals all throughout. The rotator cuff looks yellow. It looks weak. It looks thinned out. So it is dangerous to get too many cortisone shots. So, and another thing to keep in mind is as time goes on, the cortisone shots can become less effective. And if we start getting a little bit older, have more medical problems, or are just not as medically fit to tolerate a surgery, it's kind of kicking the can down the road. And, the outcomes of a surgery at that point may not be as great. Another thing to keep in mind is, are you diabetic? There's a lot of studies that show that if your diabetes is poorly controlled, a cortisone shot can actually contribute to poor diabetic control and throw you out of sync with your daily sugars, and if it's bad enough, even land you in the hospital. So we got to use cortisone injections very sparingly and not just give them too much. So non-operative management. So what happens if you treat a rotator cuff without surgery? Well, we do know that over time, rotator cuff tears don't heal, but they get bigger. So 50% of painful rotator cuff tears are known to progress at 5 years. If you have a partial tear, we know that about 2 years, 11% get bigger, but about 5 years after, 35% can get bigger, and even it progress to full thickness tears. And if a rotator cuff tear goes on for long enough and it's a full tear, it could end up scarring down and the muscle can get replaced by fat. So if this goes on long enough, sooner or later it could get to the point that the ball is no longer sucked into the socket and the other muscles in your shoulder pull the ball upwards, and ultimately it leads to a development of a special type of arthritis called rotator cuff arthritis. So how long it takes for this to happen, there's a lot of different factors that play into this, including tear location, tear size, but there are some studies that show that within 5 to 10 years, some patients can develop rotator cuff arthritis. So here's an example. So you see the image on the bottom left, there's the ball with the socket, and you see that black line, that's a tendon connected to the rotator cuff muscle. But a few years later, you can see that that muscle has been completely replaced by white. On MRI, white means that it's fat. So that muscle has atrophied. And now, ultimately, with time, that patient is going to develop the picture on the bottom right where the ball is making contact with the other bones and now has developed rotator cuff arthritis. So, what are the indications for rotator cuff repair? So, generally, as long as you're healthy and fit, any type of an acute tear is an indication for rotator cuff repair, because we know regardless of how old you are, if you have a fresh tear, it's a very good healing environment for the rotator cuff. So if we fix it, we can get it to healing and restore your function and strength and quality of life. Also, acute tears have been shown to go on to the irreversible degenerative changes such as a replacement by fat at a higher rate than just your chronic degenerative tear that gets bigger slowly over time. Partial tears. So if you have an undersurface tear on the bottom that is approximately 50% of the tendon and you haven't gotten better with PT and maybe one injection, that's a good indication for a surgical repair. Tears on the top of the tendon are treated more aggressively because these have been shown to progress more rapidly. So even as low as 25 to 30% of the tendon being torn over the top is a good indication for surgery. But again, this is if you've done physical therapy and you're just not getting better. Full thickness tears in younger active patients with healthy cartilage in their shoulders are always a good indication for rotator cuff repair, because again, we're trying to improve your function, your strength, and prevent your shoulder from getting worse over time. When patients get over 65, generally, because we know the healing rates do go down after rotator cuff repair, it's not unreasonable to start with a trial of physical therapy, maybe one injection, and see how you do. But in that situation, if you're not improving, then it's completely reasonable to go in and do a rotator cuff repair, understanding that we haven't responded to conservative management, and the goals of our surgery are the same: improve your pain, improve your strength, and prevent your shoulder from getting worse. Medium to large tears, we know that those progress to irreversible changes and even arthritis down the road. So that's another very good indication to go in and do surgery, as long as you're medically fit and don't have too many medical comorbidities that put you at high risk for not healing. So recovery, it usually requires about 6 to 8 weeks of immobilization in a sling. We start physical therapy about 2 to 4 weeks after surgery, and it is a long recovery. It's very difficult. So you could have pain and stiffness for upwards of 4 to 5 months after surgery. And ultimately, it takes about 1 year for you to hit your maximum benefit. And it's very important to be compliant with what I tell you and also what the physical therapists tell you to do and not to do, because when they do tear, 95% of the time, the failure happens within the first 6 months. So at that point, even if it's 6 months after surgery, the rotator cuff may be starting to heal, but it's still not going to be strong collagen. It's at risk of tearing if you do something that's too strenuous. But if it does heal, patients do well, but there are certain things to take into consideration. So healing rates depend on a lot of factors, tear size, again, patient's age and health, the technique, the chronicity of the tear. So we know in general, a small to medium-sized tear heals at a rate of 70 to 90%. As tears get bigger, the healing rates go down. So the studies have shown that large and massive tears sometimes heal at rates of 40 to 70%. But again, we have to take into consideration the patient's age, their health, the quality of the tendon at the time. And these are based off a lot of studies with different factors. But in general, it's safe to say that smaller and medium-sized tears heal at a much higher rate than large and massive tears. Patient-related factors. We know based off substantial evidence that healing rate decreases if you're a smoker. So studies have shown that the healing rates between a small to medium-sized tear can go from 70 to 90% down to 50% if you're an avid smoker, because again, smoking leads to issues such as decreasing blood supply to the tendon. It inhibits the cells that lead to collagen production and repair of the tendon. So overall, it's not a good idea to be smoking if you're planning to have a rotator cuff repair. In terms of age, there are studies that show that, it's always better to address a full thickness rotator cuff tear when you're younger as opposed to older. So the average age of people who heal are in their mid-50s. The average age of people who don't heal are 63 and older. And there's been some good studies that show that once you start getting to 65 or 70 years old, your healing rate can go down to 43%. But again, there's a lot of things to take into consideration. Not all 65 and 70-year-olds are the same. We look at our physiologic age and your health and your activity level and your expectations and demands on your shoulder when we start formulating these plans. And it's very important to talk to your doctor, and we talk together to try to figure out what's the best option for you as a patient, as opposed to just going off statistics. So I think at this point we could open the floor for questions.
All right. Great, Doc. Thank you. Let's go ahead and open up for any live questions. Feel free to unmute yourself, and let's just be respectful of each other. Ask a question if you'd like, and we'll start the process. I know one thing that comes to mind with a rotator cuff injury is the other side of the body. So whichever side is the problem, say it's your left side, how does the rest of your muscle group correspond to the injury itself, and how do you mitigate those kind of muscle issues?
Do you mean so if you're talking about a left rotator cuff tear, we're talking about your right shoulder?
Yeah. In the process of the healing and post-surgical or any combination thereof.
Well, sometimes it is tricky because when you are recovering from a rotator cuff tear or repair, you do have to depend on your other shoulder because you are out of commission on the side we did surgery on. And, based off the statistics that we've talked about, there is a high number of patients who have a rotator cuff tear on the other side that may have been just resting dormant and not causing symptoms, but now the pain has flared up because you're overusing it. So it is something to keep in mind, as we get older. There's plenty of evidence that, rotator cuff surgery recovery is very long. There's just not much way around it other than having to depend on your other shoulder. But if you start developing pain in the other side, it's not unreasonable to start with an injection, start with some physical therapy on the other side while you're healing from your other rotator cuff.
Great, thank you. Go ahead.
Can you talk about some things that we could do as older folks to kind of keep our shoulders in good health for as long as we can?
Well, I think number one, uh, doing rotator cuff strengthening exercises, again, keeping your shoulder blade healthy is always going to be helpful. There are a bunch of different muscles that attach to your shoulder blade. And oftentimes when it starts hurting, it's because you fall into a bad position of having your shoulder lean forward or be protracted. So working on rotator cuff strengthening exercises, band exercises, keeping your shoulder blades back, keeping the space between the rotator cuff and the bones open, that can always help prevent symptoms from developing. To date, we haven't really come up with any answers on how to mitigate the development of rotator cuff tears in terms of stopping the process, whether it's nutrition, things like that. We haven't figured out a good way yet, but the factors that we can prevent are: don't smoke, keep a good diet, keep your cholesterol down, because these are things that we know do contribute to pathology of the rotator cuff as we get older.
Great. Let's go to Harriet first, and then we'll go to Hannah. Harriet, did you have a question?
Yeah, I sent you a message and I wondered if I need anything more than what I'm doing. I'm going for PT and I'm going for chiro visits. And my MRI showed basically tendinosis with a moderate low-grade intersubstance tear of the rotator cuff. So there was no definitive high-grade or full thickness tear, and I'm 83.
Yeah, physical therapy, especially with the type of findings that you're describing on your MRI, those are very common once you get above 80. So again, 54% of people over 60 have some sort of pathology in the rotator cuff, and the findings that you have are very common. So getting your shoulder strong, getting it compensated, restoring your normal motion, it's been shown to be very effective. And if you're doing therapy or you can't tolerate therapy and it's not getting better, then one cortisone shot is perfectly reasonable for you.
I used to get cortisone shots from, if you're in the Eisenhower Desert Orthopedic group, I was getting them for quite a while until he decided that I shouldn't have any more. So I don't know if I should start that again.
I would come in for evaluation first. We'd want to look at, rotator cuff tears, partial tears. A lot of times they occur with other issues too. You may have a little bit of arthritis in your
I
shoulder.
have a lot of arthritis, I'm sure.
Yeah, well, if there's a lot of arthritis in there, then that's usually the main culprit, because about 20% of people with arthritis are going to have some pathology involving their rotator cuff. And it may be the bone on bone rubbing that's more of the pain than the actual rotator cuff itself.
Well,
So
my biggest concern is that the tear will get bigger.
well, if you do have severe arthritis and the tear gets bigger, the surgery for arthritis when you're in your 80s, severe arthritis, is a shoulder replacement. And
Oh, no.
whether or not there's a partial tear or a no tear, it doesn't really change the management or the outcome of a surgery, because patients, even with arthritis and a rotator cuff tear, or patients with arthritis and no rotator cuff tear, still respond very well to shoulder replacement if that's the right indication for you. So a lot of times patients are worried more about the tear, versus the arthritis, but at the end of the day, the surgical management would be the same. If someone has severe arthritis and you have just your rotator cuff fixed, it actually can lead to worsening of symptoms, because you could become more stiff and more painful secondary to your arthritis from the surgery involving your rotator cuff.
Okay, so I guess I'll just come in and have an evaluation.
Yes, I think that would be a great idea.
Thank you.
All right, great question. Let's go to Hannah. Did you have a question you want to unmute?
Yes. What I wanted to ask, I'm under treatment. I've been getting physical therapy. I have tears in the rotator cuff in both shoulders. Right one is worse. I also have arthritis, and I have an autoimmune issue that affects my connective tissue. I am not gung-ho on shoulder replacement at all. I'm 80 years old. I really don't want to do that. I'm 39 years ago, I stopped smoking. I was a heavy smoker. Is there rotator cuff repair without doing shoulder replacement?
I'm sorry, ma'am, how old were you?
I'm going to be 80.
So if you have severe arthritis and you're in your 80s and you have a full thickness rotator cuff tear, I would not recommend a rotator cuff repair because I think the incidence of getting it to heal or the rate of getting it to heal will be very low. And I think you could still have a lot of pain in your shoulder secondary to your arthritis. So sometimes patients don't want the shoulder replacement. Sometimes we could do more of a minimally invasive approach, like going in there and doing a clean out procedure. But to be honest, those results are very unpredictable. And if you have severe arthritis, a lot of times they don't help. There's other things we could try, like, PRP injections. But again, there's kind of, controversial evidence as to whether or not that can be approved, that can be beneficial for you. But a lot of this, again, comes down to physical examination, seeing how much motion you have, seeing how bad your arthritis is, and then really, tailoring the management and plan for you as a patient based off of our findings.
Physical therapy has been giving me some help, and I have a little less pain. I'm able to sleep without as much pain. But I do take, meloxicam, lidocaine patches, etc. But thank you very much.
My pleasure.
All right, let's go to Carolyn. I think you had your hand up.
Yes, thank you. And thank you, Dr. Otarodi, for your lecture. I really appreciate it. I was diagnosed with a slap tear of my shoulder 5 years ago, and I was a working RN at the time. I did not want to have surgery. And over the last 5 years, I've really lived with it, doing pretty well. But of recent, the last few months, my shoulder had been bothering me. I am retired now, and I have just recently started physical therapy. I'm going to be 70 the end of this year. So I guess my question to you is, should I continue with physical therapy for a few months and see how this goes? Or should I make an appointment again in a Desert Orthopedic Center for another follow-up? I'm hesitant to have surgery. I've had spinal surgery over the years, and I also have a diagnosis of psoriatic arthritis. I do see a rheumatologist. So when you mentioned about night pain, that is a real issue for me. And I just don't want things to progress without, maybe getting another answer. So I just wanted to see what your opinion is, if I should just stick with physical therapy for a while longer and see how it goes.
Well, I think it's always helpful to come in for evaluation. If you
Right.
ever have anything bothering you or concern, I would come in to get it checked out.
Yeah.
In terms of slap tears, so slap tear means that the attachment of the biceps at the top of your shoulder socket on a structure called the labrum is torn. So the shoulder socket has this structure called the labrum that goes around it. And when you're younger, the labrums are very important for stability, but as we get older, it becomes less important, and the rotator cuff takes over as the #1 stabilizer. Well, when you're above age 40, the labrum does start getting tears, and it's very common to have these slap tears or labral tears in the shoulder. And usually they're not the main pain generator in your shoulder as you get older. If you do have psoriatic arthritis, that could be the #1 cause, and any type of inflammatory issue in the shoulder can lead to degenerative changes of the biceps or the labrum, the slap tear. So I think it really comes down to, getting some up-to-date x-rays, seeing do you have bad arthritis in there, doing a physical exam, seeing if the pain's coming from the biceps or the slap, or maybe even a partial tear of the rotator cuff. So a lot of it depends on your exam and your imaging findings. But I tell you that, when you're 70, going in there to do surgery on a slap tear is very uncommon. And if it does look like it's contributing to pain based off examination, sometimes most of the time, what we do is just take the biceps off of that part of the labrum. So it's no longer cutting it or pulling on it and causing pain. And we attach the biceps somewhere else. So going in there and actually doing a labral repair when you're in your 70s is very, very, very unusual. And there's a high likelihood that the slap is not what's causing your pain, and it could be something else. So yes, I'd say it would make perfect sense to come in and get evaluated.
Okay, thank you. Thank you very much for your time.
My pleasure.
All right, give me 1 sec. We're going to answer a question in the chat, and then we'll come back to live. Can a small 1.1 centimeter complete tear of the supraspinatus tendon with mild retraction and no significant muscle atrophy or edema, can this heal on its own? And it says, I have done PT, oops, here we go, for 2 months and continue with exercises 3 to 5 times a week, 69 years old.
So the rotator cuff does not heal on its own. The goal is for the rotator cuff to not progress as time goes on. So 1 centimeter tear is considered small. Most of the time at 69 years old, the rotator cuff where it's torn will be in an area where the blood supply is limited, called the rotator cuff crescent or the degenerative zone. So usually if you have a small 1 centimeter tear in this area and you're over 65, therapy can be beneficial. We could even start with a cortisone injection. But if one cortisone shot and therapy do not help, then it's completely reasonable to go in there and do surgery. On the other hand, if you say I've done physical therapy for a few months, I've been very, diligent about doing it. I can't sleep at nighttime. It's affecting my quality of life. It's also not unreasonable to go in there and just fix it. But a lot of it does depend on what the MRI looks like. Where exactly is that 1 centimeter tear? But usually, a 1 centimeter tear can respond to conservative management. Maybe we just need to do 1 injection on top of it, but I definitely would not do more than 1. I would just give it 1 injection, some more PT, see how it goes.
All right. And we have a hand up in the room. Feel free to unmute yourself, who you think you have, and ask the question. I'm not sure who there's no name attached, but if you have your hand up and you would like to ask a question, please do so.
Hi, my name is Linda, and I had an x-ray about a week ago after experiencing pain in my left shoulder since January. I think I did it helping my daughter move, lifting. I'm 68 years old. I just got in for an x-ray with an orthopedist, and he determined that I have a calcium deposit on my upper shoulder, and he asked me about impingement, suggesting it might be impingement, and I received an injection and was referred to physical therapy. Can you speak to this?
Mm-hmm. Yeah, so it sounds like you have a diagnosis of what's called calcific tendonitis. So it's actually a very common thing that happens. So sometimes the cells inside your rotator cuff that usually produce collagen and nourish the tendon and take care of it can undergo a change to a different type of cell that actually lays down calcium. But it's not like rock hard calcium like in your teeth or your bones. It's more of like a gelatinous material that honestly looks like the caulking that you would use, in your bathroom to do some repairs. And a lot of times that can cause pain and inflammation and a lot of stiffness in the shoulder. It's perfectly reasonable to get 1 cortisone injection and do physical therapy. And sometimes that calcium actually just goes away or resorbs on its own. But if you do the injection, you do the therapy, it's just not getting better, then we usually recommend going in there and doing a clean out procedure. So this is an arthroscopic surgery. Go in there, small incisions, look inside with the camera, find the calcium, remove it. And your recovery really depends on what the rotator cuff looks like once it's out. Sometimes it's all on the superficial aspect of the tendon, and the tendon's completely intact after the calcium comes out. and then you're looking at like a 2-3 month recovery. But if it involves a substantial amount of the tendon and then we have to take it out and leave a small defect in the rotator cuff, then you need to have that fixed because we can't leave you with a rotator cuff tear. That does increase your recovery time. Then you'd be in a sling for 6 weeks doing the rehab, and ultimately it could be upwards of a 1-year recovery. But to answer your question, calcific tendonitis is very common. We see it all the time. And the appropriate first line management is to do an injection, some physical therapy. And if it doesn't get better, then we talk about surgical indications and options.
How much time should I give it? And I was also concerned because I have Kaiser, and it took me from January to go through the process to get referral to last week to finally be seen and have an x-ray.
I would say usually, 8 to 10 weeks of physical therapy, maybe a little bit longer to see if it's improving. But if it's just not improving or you just can't tolerate the exercises because they hurt too bad, then it's not unreasonable to actually start talking about surgery.
Thank you. I have one more question. I was told to return to normal activity, and I do work out with small weights, 4 to 5 pounds. And I was told this is okay. Just want to run that by you.
It's hard for me to say without actually confirming the diagnosis, but in general, if the diagnosis is calcific tendonitis and there's not another issue going on in there, I think it's reasonable to, let pain dictate what you do. So if it doesn't hurt too bad, then yeah, I would return to some light weights, see how you do. But if it really aggravates your pain or you just can't tolerate it, then I would scale it back.
Thank you
All right.
very much.
Great. We'll have another question. Just 1 second here. It says, I think there's a question here. It says, I'm 68 years old and was diagnosed with a left shoulder tear from about 7 years ago. Nothing more than a range of motion and x-ray to diagnose. 5 years ago with a right shoulder tear. I've not had PT. And I think the question here is, and are there any other treatments for things like cancer have any effect on shoulder treatment that you're recommending? If they're already undergoing some other kind of cancer treatment, would that have any effect on other treatments you'd be recommending?
No. I mean, if someone's getting treatments, for cancer, what our standard recommendations aren't really changed. Sometimes if someone's on a blood thinner, then we say that you shouldn't take anti-inflammatories, or if you have chronic kidney issues, we say don't take anti-inflammatories. But in terms of, the injections, physical therapy, that would not really be contraindicated if you're having another treatment for another major medical problem such as cancer.
Great, thank you. And then looks like Harry, I think you had your hand up. Feel free to unmute and ask a question.
Hi, I am 76 years old, and I injured my shoulder playing tennis in February. I went to the doctor. I had an x-ray that shows negative as far as any arthritis or anything like that. I was referred to PT. I just completed 5 weeks of PT with and I haven't had any positive results. I still have the pain and there's no strength in my shoulder or in my arm. I have not had an MRI. What would be my next step to take?
I don't think it's unreasonable to get an MRI at this point. Especially it's been going on for 5 months. You've been doing 5 weeks of physical therapy. A lot of times it could take 3 to 6 months of therapy for this to get improvement. But if you're really not seeing any changes, I think it's perfectly reasonable to get an MRI.
All right, and you mentioned injections. Is that a possibility too?
Yeah, no, an injection is perfectly reasonable. Depending on your exam findings. So again, if you come in and there's evidence of, some weakness with the rotator cuff, 76 years old, 1 injection, physical therapy, completely reasonable. If that doesn't work, then, get an MRI. But again, if you came in and said that, I'd like to get my MRI right off the bat, so I really know exactly what's going on in there to help guide my decision-making as a patient and as a doctor, I think that's completely reasonable. So I think both are just
That's for a referral.
good options.
And so I should ask my doctor for a referral for an MRI then, is that correct?
Yeah, or you could come see us and we could order it ourselves. That's fine.
I have Kaiser and,
Oh,
so.
I think,
Ask for a referral for orthopedic.
yeah, it's usually with Kaiser, it's better to just come through us and then we could order that. And I think with Kaiser, we're able to actually get the images done in our center where, you know, we could have easy access to it and also look at it ourselves, and our radiologist will look at it. So I always think it's better just come through to us.
Oh,
Okay.
okay. Well, thank you very much.
My pleasure.
All right, another question in the chat. It's pretty broad, so if you hear this question and want to elaborate, please do. Is there anything bad I can do exercise-wise to hurt myself? And the follow-up here is I am right-handed, seatbelts are hard to put on.
Yeah, it's hard for me to answer that question because there are so many things. I would say just you know, if you're not an avid exercise person, ease into it. You know, work with a trainer, someone who could supervise you. If you're experienced, do things, you know, at your level. Let pain dictate what you do, but it's hard to say, you know, this exercise is bad or that's good, without, you know, having a full understanding of your history.
Great, thank you, doctor. All right, that's the chat and currently the hands raised. So if there's other questions, feel free to, we have a couple more minutes, but feel free to unmute and ask the question of the doctor. Give it another minute here. Oh, there's a question. Say yes, and I was going to probably follow up on this, but can I ask Kaiser to refer me to you? I've only seen a PA.
Yeah, I think that should be perfectly reasonable. Just well, with Kaiser, they usually will put in a referral for you to come to the orthopedic department. Then it goes through our triage center, and they usually come to see us. So if you put my name in by specific request, that'll have you come see me. Otherwise, you could sometimes go see a PA with one of my partners first.
All right, thank you. Yeah, the key there is just call Desert Orthopedic, explain to them their medical insurance, who you're coming through, and then they'll guide you appropriately within the system and or the referral process, everything to get you to see the doctor you want to see. All right, any last questions? I know we're getting close to time, but we have time for another question or two. If you have any, please unmute and just ask a question. All right, I'm seeing lots of thank yous come in, but no questions at the moment. Any last thoughts from you, Dr. Otarodi?
Well, you know, just we're here more than happy to help anyone with any concern they have. You know, no problems too big or too small. You know, we take care of all things at Desert Orthopedic Center, and you know, I like to think that there's, you know, nobody in the country that, you know, has a broader group with more you know, skills and opportunities to help patients. So anytime you need anything, just come through and see us. We're more than happy to help you all out.
Great. One last question that came in. So the question is, in regards to pain management, I know within Desert Orthopedic, we also have pain physicians that specialize in that. So how does that process work if someone is seeing you or seeing a pain management first?
Well, the pain management doctors, they really focus more on non-operative techniques for musculoskeletal issues involving the spine and back. When it comes to shoulder issues, you know, you're more than welcome to go see them, and they are all top notch. But we do have 3 shoulder elbow specialists, another sports specialists, and we're all, you know, have the full breadth of experience to take care of all shoulder issues. So if it's a neck or back issue, usually you go over to see the pain management doctors, but sometimes they do manage shoulder issues too. But in general, usually the shoulder issues come to one of us.
Fantastic. Perfect. All right. Well, with that in mind, we are just about at time, and think that was the last question in the chat or online. All right, well, Dr. Otarodi, thank you so much for a very informative lecture. And then again, for everyone, this was recorded. It will be edited within the next 7 to 10 days, and then we'll have it online. And I will send it out. If you registered, which everybody here has, I will go ahead and email it to you, so you'll have the link for viewing and asking more questions or referrals. All right, with that in mind, thank you very much for being part of our Desert Orthopedic lecture series this season, and we will be back. You'll see us online. You'll see us in some podcasts starting in July and into August through the summer, and then we'll return to live and some in person and mainly on Zoom, but we'll have some in-person lectures coming up in the fall. So have a great summer and stay as cool as you can.
Right. Thank you.
Thank you, Doctor.